Hello, everybody. Welcome to today's webinar, Beyond COVID, the Business of Healthcare. Today's webinar, as usual, being presented by Smith Business Insight and by Queen's Executive Education. My name is Meredith Dalt, and I'm a business journalist at Smith School of Business at Queen's University at Kingston, Ontario. Before I introduce our panelists, I want to remind you, as I always do, that today's conversation will be recorded. You will be receiving a link to that recording in your inbox within a day or two of this conversation. I also want to urge you to please consider asking a question today. We have a remarkable panel, and you do ask a question by using the Q&A button at the bottom of your screen. We will be devoting the last 15 or so minutes of the conversation to answering those questions. So please get them in early, and we'll get to your questions at the end. Now, we have 4 guests today, each as accomplished as the next. It's my pleasure to first introduce Jane Philpott. Dr. Philpott is the Dean of the Faculty of Health Sciences at Queen's University, and she is the CEO of the Southeastern Ontario Academic Medical Organization, or CMO. Do I have that right? Do you call it CMO? She is also a former Member of Parliament. Prior to politics, Jane was a family doctor for 30 years and spent the first decade of her career in Niger, West Africa. She was Chief of Family Medicine at Markham Stouffville Hospital and an Associate Professor in the Faculty of Medicine at the University of Toronto. From 2015 to 2019, she served as Federal Minister of Health, Minister of Indigenous Services, President of the Treasury Board, and Minister of Digital Government. She has recently been appointed as the Minister's Special Advisor to the Ontario Health Data Platform. Thanks for being here, Jane. Mark Rochon is Senior Executive Advisor of Global and Canadian Healthcare Practices at KPMG Canada. He has more than 25 years in senior healthcare leadership experience, including as Interim President and CEO of Health Quality Ontario and Interim President and CEO of the Ontario Hospital Association. He was founding President and CEO of the Toronto Rehabilitation Institute and founding CEO of the Health Services Restructuring Commission, where he led a province-wide initiative to reconfigure Ontario hospitals and other related elements of the health service system. He also served as President and CEO of Humber Memorial Hospital. Mark has been an advisor to government on the policy and legal framework that governs the operation of hospitals, as well as healthcare funding reform. He is the co-author of Riding the Third Rail, the story of the Health Services Restructuring Commission. Thanks for being here, Mark. Scott Carson is a professor at Smith School of Business, specializing in governance and strategy. He is formerly the Stauffer-Dunning Chair of Policy Studies and Executive Director of the Queen's School of Policy Studies. Scott's career has combined business, government, and academe. He was the head of corporate finance for a major Canadian bank, CEO of an Ontario government secretariat, and the dean of 2 Canadian university business schools. He is the former chair of the board of He is the former chair of the board of Kingston General Hospital. He is the co-editor of 3 recent books on Canadian healthcare governance, Towards a Healthcare Strategy for Canadians, Managing a Canadian Healthcare Strategy, and a Canadian Healthcare Innovation Agenda, Policy Governance and Strategy. This is his 2nd appearance on a Smith Business Insights webinar, so we're pleased to have you back, Scott. Thank you. And finally, Don Drummond is the Stauffer-Dunning Fellow and an adjunct professor at the School of Policy Studies at Queen's University. In 2011 and 2012, he served as chair of the Commission on the Reform of Ontario's Public Services. Don previously held progressively more senior positions in the areas of economic analysis and forecasting, fiscal policy, and tax policy during almost 23 years with Finance Canada. His last 3 positions were, respectively, Assistant Deputy Minister of Fiscal Policy and Economic Analysis, Senior Assistant Deputy Minister of Tax Policy and Legislation, and most recently, Associate Deputy Minister. He subsequently was Senior Vice President and Chief Economist for TD Bank, where he took the lead with TD's economics work in analyzing and forecasting economic performance in Canada and abroad. Don, thank you for being here. I'll invite you all to unmute your microphones. Those are very impressive CVs. I feel exhausted already just from reading them. What a wealth of knowledge to have you all here with us. So I'm going to invite you, let's just start with a general conversation about looking at where we are. We're in the thick of I guess, is this the thick of the second wave or the beginning of the second wave? Anyway, the second wave is weighing heavily upon us already. What do you think our health system has got right so far? What are we doing well? Jane, you want to start?
Great question. And of course, your question introductory about whether we're actually at the beginning of the second wave, are we nearing the plateau, or what's ahead? I don't think any of us will be able to answer that, but it's certainly an opportune time to talk about what we have done well and not so well. I would say the thing that we've done the best is that we're collaborating better than ever in health systems. So we got caught off guard in the early days, and that's why the mortality rates were so high in the first wave in Canada. We, the number of deaths in long-term care systems were truly tragic. But that was a big wake-up call. Hospitals have traditionally paid most attention to what happens within the walls of hospitals, and overall the healthcare system, because hospitals are such great drivers of the costs of health systems, we have turned our attention there first. And I think that's what we did here, was looked at making sure hospitals were prepared. In the meantime, we had our eye off the ball, and where the pandemic was spreading was in the long-term care systems. As a result of that, there was a pretty rapid transition to say, oh my gosh, this is a big picture. We've got to do better together. And you can see that in the second wave, because everybody immediately started to say public health, hospitals, primary care, long-term care, all have to look out for each other. And we have effectively, I think, staved off those high mortality rates in the second wave as a result of that collaboration.
Amazing. Anyone else want to weigh in on what we've done well, just to kick us off, beyond what Jane has mentioned?
I was actually surprised that sorry, Mark, go ahead.
First of all, I need to say that the views I'm about to express are my own and not those associated with KPMG, or necessarily those associated with KPMG. I agree with Jane that in many respects, the success of the health system trades on our ability to work together in an effective way. And it's a loose relationship of organizations that make this thing work. And in the absence of, I think, working together, society is at peril. And I think we've learned from that. I agree with you, Jane. And I think what we will see, hopefully, in the next wave of the pandemic is more immediate responses to issues. We can't use the time scale that was in, quote, normal time. We need a time scale that's decision-making, decision-oriented, that has a time scale that's quite compressed and allows us to make reasonable moves forward in a way that's attuned to the fact that we can't wait for the normal analysis and considerations to unfold.
Okay, can you just dig into that a little bit more? So what would you like to see?
Oh, I think we need to be much more responsive in a shorter time frame. When issues come up, we can't wait for the usual processes to unfold. We need to get at it right away.
Got it. Don, you were gonna say something. Oh, you just muted yourself. There we go.
Well, I don't like to have a panel. Everybody's agreeing with each other, so I'll go in the other direction. I find it hard to press to identify something we've done well. Certainly in the first 2 months, we were touting what was just said about the improvement in coordination. And of course, the thing we've all hated is these really high alternative level of care numbers in the hospitals, where people who shouldn't even been there in the first place are still there, and they stay in there a lot longer than the people that are supposed to be there. And the hospitals did seem to do a reasonable job of addressing that to out the room. But fast forward, first of all, if you map where they went, they were often sent into very dangerous locations in the long-term care. So that wasn't very good. And you fast forward right now, the alternative level of care numbers are back where they were pre-COVID. So I think we have to take that one off the table. We got billing codes to do phone and email addresses. That's great, but I think you have to, why the heck did it take a pandemic to cause that? That was done literally over a week, and it was a simple discussion. Clearly that could have been done before. I thought until about a month ago that one of the things that would last from this thing is we would finally take public health out of the basement of the healthcare silos. Now I'm not so sure. They clearly have risen in prominence over the last couple of months, but you can see a fatigue settling in. And I'm not sure. I think if we're not careful, they're going to be stuffed back into the basement. So I'm not sure we could do that. I would take the point that Mark made, but take it out of the health realm. I think the most amazing thing that's happened in the last 6 months is we've shattered a mythology that governments can't react to things quickly. Unfortunately, I don't think they've reacted terribly quickly or very well in the health domain, but on other fronts, on the income support, and they made lots of mistakes, and part of them because of their haste. But I still think it's breathtaking from both a policy design, when you look at the Canada Emergency Relief Benefit, how quickly he designed it, but from an administrative perspective, imagine the Canada Revenue Agency processing 9 million of them within weeks. An institution that wasn't even geared up to do that, that had been in a different government department, and they're all scattered all over the place, working out of their homes, and still they did that. So I think that one thing that sticks in my mind from this experience, never again should we take as an excuse that it's going to take too long or it's too complex, because we can see when there's a recognition of a need, we can move with blinding speed, maybe not exactly in the right direction. And so that's my context. There was all kinds of things wrong with health in Canada before, and there will be all kinds of things wrong before. And I think the one lesson is maybe there's a greater chance now that we can actually address them due to this experience.
Wow, all sorts of stuff there. I want to let Scott have a word, and then maybe we can unpack some of that stuff. Scott.
Maybe just to follow on Don's point about the, excuse me, the speed of response. I thought it was quite impressive that with lots of miscues, of course, that the feds did a pretty good job at rolling out a lot of measures to sort of shore up the balance sheets of families and small businesses, sort of take away a lot of the bankruptcy risk early on. And the Bank of Canada, I thought, did a pretty good job at ensuring the liquidity of the bank system. So, but as a context, being a bit of a political junkie and watching the U.S., I've always been very, very impressed by the chief health officers of each of the provinces and the federal government, day after day after day, calmly and factually sort of rolling out the events of the day in a very truthful way, which is a huge contrast with the U.S. The message was a little bit choppy at the very beginning about masks, but masks, distancing, and hand washing have been consistently doled out through each of the provinces, which is good. And there's a certain civility and civicness that you see in Canada toward people more or less going along with this. You know, the huge contrasts are, of course, you look at China at one end of the scale and the US at the other. You know, the Chinese are able to implement policies and procedures in a way that we wouldn't be able to do, and the US is struggling with it. But we, for the most part, second wave notwithstanding, or whatever's happening now, Jane, we've, I thought, done a pretty civilized, decent job. And of course, living in Nova Scotia as I do now, the Atlantic bubble has been superb.
Lucky you. Anyone want to weigh in? Are any of you chomping at the bit? I mean, you've all raised so many valid and interesting points. It's hard to know even what direction to take things in. But in terms of like changes in the system or in policy, you know, what do you see happening, or what do you want to see? Is that a next best place to take this conversation?
I
can launch on that, because I know what I want to see, and it doesn't particularly have an awful lot to do with the pandemic. And I think if we're going to pull off what I would like to see in the health field, it won't be because of the pandemic or the responses. It'll come back to these problems we had before. So I guess we're speaking at a business school, and maybe some of them think about it in terms of a business proposition. We have, next to the United States, one of the most expensive healthcare systems in the world, and we have mediocre health outcomes. That's a problem, isn't it? That says something about effectiveness and efficiency, something business students would understand. I guess even be more in the business line, think of life as a production function. If you're in a business, you have a pretty good idea what's on the left-hand side of the production function. We got the wrong variable on the left-hand side. How serious is that? Our variable on the left hand is healthcare. Everything is geared to healthcare. It's geared to patching up people after something's gone wrong. We don't gear it to the promotion of health. And a victim of our history when what we have right now was established in the 50s and 60s. We had only 7% of our population was in the seniors. We did not have multiple morbidities. We didn't have chronic diseases. We had a young population that got things like the flu or the broken arm, and we built a system to deal with that. And we still got that. But we're about to go from 1/6 to 1/4 of our population being elderly, and that's not the need. And we're not designed. I mean, look in the world where Jane Philpott is. We have 304 gerontologists in Canada. And I'm not missing a digit. It's 304. I can name them all by name if anybody wants. We have 470 rheumatologists. We are not prepared for this whatsoever. And yet there are some things in life you can predict with high accuracy, and we can predict the age profile and the health profile of the country, but we're just not geared to that. Every ounce of the health system is geared towards that healthcare. Our form of, business school, fee from service, still 80% of the conversations, fee from service. What incentives that gives? It gives an incentive to service. If you looked at somebody who is healthy, that wouldn't be particularly attractive if you're trying to maximize your income. How perverse is that system? I'm hoping these kinds of problems that have been there for a long time will come to root, and with this acknowledge now that we actually can do phenomenal things and move things at a faster pace, that maybe we'll actually get somewhere this time.
Okay, Jane, I want to bring you into the conversation. You want to respond to Don, or did you want to?
Well, sure. I'll respond to a couple of things that Don said. I mean, in his first comment, he referred to our lack of focus on public health, and will this actually teach us to get public health out of the basement of the healthcare system? And I share his anxiety about whether will have really learned our lessons in this. It's the least funded part of the healthcare system, and has been under-resourced, fragmented, and has lacked the teeth from both a legislative and policy perspective for a very long time, and we've to a large extent paid the price on that. But the other thing I cannot overemphasize Don's points as well, in terms of the fact that the things for which we are most proud in our healthcare system were designed half a century ago, when healthcare was delivered by doctors largely, and not by a vast array of professionals who are more affordable and sometimes better positioned to be able to provide the care. And it was focused on hospitals. So, care is increasingly provided in the community. So again, from the business point of view, we do need to look at the fact that, we've got to modernize our approaches to healthcare so that we do get better health outcomes for the dollars that we spend, which are way better than our partners our neighbors to the south of us, but not nearly as good as they are in many European countries. And from business schools, and all Canadians should actually care about how we can actually modernize health systems. And let me tell you, from the perspective of government, it's very, very hard to do, but I don't believe it's impossible.
It's interesting that nothing we've said, and especially the points that Don made, have much to do with COVID. They are the chronic parts of a healthcare system that really isn't very much attuned to the chronic nature of disease and illness of seniors. But I mean, the Queen's, a collaborative effort of Queen's University, and Don knows this well because he was part of the organizing committee of this, between 2013 and 2016, we ran 4 conferences on the general question is, could Canada have a pan-Canadian healthcare strategy? And I know Don has always kind of shaken his finger at me for my sort of schoolboy, beach boy, wouldn't it be nice if we could kind of attitude toward it. But there are many sectors of within healthcare that have been for a long time calling for sort of an overall national or pan-Canadian healthcare strategy, even an umbrella strategy that incorporated all of the provincial concerns. And of course, high up on that list was seniors care. Where Jane, the CMA has issued multiple reports calling for pan-Canadian strategies. Canadian Nurses Association has done the same thing, even back to the Romano report, on and on and on and on and on and on again. So the question is a COVID going to be that great catastrophic impetus for something actually to move a more national pan-Canadian approach, even if it's to seniors care, never mind pharma and everything else besides.
Yeah, I think to me, it will hopefully generate action as a catalyst, because a couple of things were exposed that I think are really quite key. And one Don referred to is just how close to the edge of capacity the health system operates. And it doesn't take much to just put us over that edge. And in this case, it's a significant issue that caused a number of organizations to have to regroup and rethink how they provide care. And you see it in the, ratcheting back of elective procedures and into other interventions that could be delayed, or maybe not delayed, but had to be delayed because of circumstances. So I think it'll cause us, I hope, to have a serious conversation about how to rebalance the health system. Because I don't think it's a matter of money, it's a matter of how we spend it. And we probably spend it in some of the wrong places. The other policy question that I think needs to be addressed, and again, this isn't something that is new as a consequence of COVID-19. It's been around for a while. It's how we use our human resources in healthcare. I mean, there is a predicted shortage worldwide of healthcare professionals and healthcare human resources as we get into the next decade. So what does that mean? And I think it really ought to generate the debate about how we use the health professionals we have now, how they work together as teams, and the extent to which scope of practice can be modified so people can work to the limits of their scope in a way that is collaborative and not seen as sort of a negative response to infractions on somebody's guild. And I think it's an important issue for us to consider, because we all know we spend about 80% of our dollar on human resources in healthcare, and I don't think we do a good enough job deploying them.
It's an interesting point, and I know Jane is going to have a fix for this now, the dean of a medical school. But health human resources are a major sort of issue in Canada. So somebody graduating in one specialization in Jane's new shop pretty much can choose where to practice, not necessarily in the place where it's most needed, or choose a specialization that's particularly remunerative and not particularly what could be most needed somewhere else in Canada. So one of our big challenges is to try to align a publicly funded health education system for docs and nurses and so on with the demand of the marketplace and with the needs of the country. So Jane, what's the solution to that?
Well, it's interesting that you raise that, because that's a very live discussion, and I do think the pandemic has stimulated a little bit more interest from governments to have that kind of conversation. Even not just, as you say, within, do we train X number of doctors and this many nurses and this many physiotherapists, et cetera, but even within medicine, for example, as both you and Don referred to, why are we training more pediatricians than geriatricians, for example? And do we need to draw people into medical school based on some idea as to where they intend to practice afterwards? And those are some innovations around health professions education that I think the pandemic has triggered. And we'll see what kind of appetite there is within governments to potentially open more spaces, as Mark alludes to the fact that there are some types of health professionals that we simply don't have enough of. So is there going to be an appetite in government? I think we're seeing, for instance, personal support workers, as we call them in Ontario, otherwise called care aides in other parts of the country, as one of the human resources in the health sector that we've almost entirely ignored, but we've seen in the pandemic that actually you cannot keep the population of a long-term care facility or a group home alive unless you're actually have a good array of personal support workers who do some of the most important work and are paid the least in the system. We're seeing some interest now from governments to say, actually, we've got to really change our policies around that.
Can we dig into that question of long-term care a little bit as people are starting to die again in greater waves? I mean, where do we start with trying to fix that problem? How do we fix the problem that we're in right now in the immediate term? Anyone?
I'll start off with telling you what's going to happen, and then I'll tell you why it's going to be a disaster, because we have long-term care reviews starting all over the country, including a commission in Ontario. And they will look and they will see that we have about 1/3 fewer workers in long-term care than the average in the OECD country. So they'll fix that. And they will look at the infrastructure is inadequate. Bob Cajun famously 4 people per room with a sheet between them, and we'll fix that. And we'll look at the safety protocols. And that will increase the cost by about 2/3. So we spend 1.3% of our gross domestic product on long-term care, and that'll take us to about 2.1. Now, what it'll miss out is we have 250,000 long-term care beds in Canada at the moment. In 2040, we'll need 500,000. We'll need more if we actually eat into the waiting list, because the 250 doesn't meet that. If you look at all forms of assisted living, we have about 500,000 today, and we'll need 1 million. And bear in mind, provinces like Ontario committing to create 15,000 new long-term care beds. That will probably just replace the ones that will be decommissioned. And again, we've known this for decades. We're totally unprepared for it. My great fear and my prediction is that the reviews will not look at the broader picture. And they will not, as we do in almost all things in healthcare, we never look at what people want. The number one thing that seniors want is to live independently. They want to create social connections or guard social connections, stay in the communities they're familiar with, but to the degree possible, they want to live independently. I don't see a lot of people sticking up their head and said, please send me a long-term care. That's the default, and yet that's almost the automatic one. And in Ontario, if you ever have the misfortune in your journey from your independent learning at home to end up in a hospital, you're 6 times more likely to be directed to long-term care than if you go through the community route. So that's a really bad way. What we need to do is what other countries do and develop home care and other forms of community living. Again, we compare ourselves uniquely to the Americans, although interestingly, the Americans have a much closer balance between long-term care and home care, with the caveat that they spend almost nothing on either one of them. But we spend $7 on long-term care for every dollar we spend on home care. If you look at Denmark, which has the highest life satisfaction for seniors, they spend more on home care than they do. Having trouble making your meals, bang, somebody provides your meal. Can't cut your lawn, bang, somebody cuts your lawn. Can't get out of the bathtub, bang, somebody's bolted a bar beside your bath. You can do an awful lot of that instead of $200 in long-term care, $1,000 of care in healthcare, and it meets what people want. Why wouldn't we generate what people want? We've been following all the wrong course, but what we're going to get out of this is more of capacity for something that nobody wants, and do nothing about how we generate what people want. And of course, then if you want to have that independent living, you have to do something to get the frailty and the dementia numbers down. It's not easy, but there are things that can be done. But again, it's on a promotion side, not addressing it after things have already happened. Just like one of the common causes for dementia is hearing ailments, and hearing aids can address that, but we don't do that. Some of them are not that difficult to tackle.
What Don is pointing out is our constant focus on institutions, which is the problem with healthcare in general, focus on hospitals and physicians rather than the broader continuum that involves many of the things preceding and after the institutional care.
Right. Anyone else want to respond to that, to what Don said, or?
Yeah, I think the point about choice is going to be an important policy issue to consider. How do you frame choice and the extent to which you can create your own care environments as you age, so that if you need high intensity care, you have more than one option, which is in an institution. There are approaches that will allow you to be safely supported in your home, how to create the conditions for supportive communities, so that it's more than the professionals that come in to help, but you have supportive communities and neighbors who look out for one another.
Right. Thanks. Jane.
Well, what my colleagues have pointed out is that, I think there's violent agreement among us on the fact that we should be moving the care of older persons into the community and into the home. And, you know, I don't think that's seen by anyone as a new revelation to us. The challenge comes with governments having the guts to do what it takes to make this happen, and getting our federal provincial relationship right to be able to say, let's make that happen. I was part of the negotiations that took place in 2016 between the feds and the province, when, you know, the federal government, you know, we don't want to get into a big constitutional discussion here, but who controls what, but the federal government, through its spending power, can actually move the levers of what happens in terms of where provinces spend their money. And, you know, the massive Canada Health transfer that takes place on an annual basis is, you know, by the provinces largely want to see that as a no strings attached transfer. But, you know, we talked earlier about the fact that, are we ever going to have a more aligned national health priorities? Are we going to have standards for home care and an expectation that people will get the kinds of services that Don was describing earlier? Well, you know, there's going to have to be strings attached to where the health spending goes, and it should include the fact that we need those kinds of expectations. That's what's worked in the Canada Health Act, is to say these are the principles by which money is going to flow, and there need to be the same kinds of standards and principles that will move health systems into the direction that we've been talking about, to say that, yes, of course, if those people who died in the spring had been cared for in a smaller community in their home, we would have saved lives. And lots of them, as others have said, would have preferred to be at home if that was ever possible for them.
So actually, I want to bring in a question from the audience at this point, which is the dual model of both public funded long-term care and private retirement homes a good model for managing an aging population?
I think choice is important. And I think that not everything needs to necessarily be funded through the public purse. And as you age, I think determining a policy regime that allows for choice and private pay is an important element of moving forward. I think people want to design their own living arrangements and their own arrangements as they age.
Or you can look at it the other way and say private delivery and public pay. I mean, there's so many procedures that are done in hospitals that could well be done outside in clinics, for example, still on the public purse. You know, there's just you have an ideological divide in Canada between those who just simply will not tolerate the delivery of, never mind the oversight or administration of, but the delivery of of components of healthcare by the private sector, and others who take more extreme views that it should be that way. But I mean, as Mark said, you could have things falling somewhere along a band where things that make sense to be delivered by the private sector in the private sector are fine. And regardless of, and then who pays for it is a separate issue. But if for those who really require it to be paid by the state, okay, fine, but deliver it somewhere else. And I think when you see the way in which the pandemic has taxed the system or threatened to tax the system, I mean, there's more of an argument for clearing the things out of institutional or hospital care to make room for the things that have to be there, and moving outside the hospitals with things that could just as easily be done there.
Meredith, the question you've asked, I think, is one of the most critical ones in terms of what are we going to learn from this pandemic. And, you know, as others have alluded to, it's highly complex in terms of, you know, you've got to look at both public and private in terms of how the care is delivered, but also public and private in terms of who pays for it. And then there is also the question as to whether it's a profit or a not-for-profit. So you've got lots of great private not-for-profit organizations that are delivering care to older persons. And some of the really interesting, very difficult to tease out data around what happened in the spring is going to be very informative to us, but hard to get at, because when you look at long-term care facilities, even the not-for-profit facilities, many of them will use services of for-profit companies that are doing the food services or the laundry or other pieces of the care. And, you know, I don't know what the final answer is going to be. There are lots of people who are going to say and want to kind of have a simplistic answer to say that the for-profit model is potentially more fatal in terms of the outcomes that we saw in the spring, but it is going to be hard to get at. We talked earlier about staffing, and if you're trying to make a profit, the easiest place to cut back is in your staffing costs. And that was absolutely a determinant of outcomes in the earlier wave of the pandemic. But we're going to have some good hard looks at how we deliver care for older persons. We're not going to transition quickly to community-based care. Institutions are likely here in some format for the long haul, and we really need to look at which of those models is in fact in the best interest of older people in Canada.
Okay, thanks. I want to shift gears just for a moment. I also think we're going to get to questions a little sooner because they're coming in fast and furious, which is a good thing. There are lots of good ones. But I want to ask the question about the shift to the virtual model. I mean, I had an appointment this morning with a doctor online from my living room. How is this shift, which happened so suddenly, gonna be kind of change healthcare going forward? The fact that
it's been around for decades in other jurisdictions. If you live in California and you're a member of Kaiser Permanente, you had access on your telephone to healthcare providers before the advent of the internet. So I think, in my view, there's no going back. I think there's such demand and desire for more virtual care that's in keeping with the needs of the patient, that I can't see us going back. I mean, to me, you know, the adjustments to the fee codes and so forth were called interim. They're not going to be interim. They're going to be baked in the long run. Otherwise, we're just reverting to old methods with waiting rooms full of sick people infecting one another, waiting to see their physicians. And I just think, I think we're on a path to see more of it. And I think as technology to support virtual care, diagnostic technology to support virtual care evolves, I think it'll be something that patients and consumers will demand in the long run.
Okay, does everyone agree? Jane, you're nodding.
Can I just throw an equity lens onto this though? Because absolutely virtual care in its increased format is here to stay. I have long been an advocate, particularly for remote care delivery using state-of-the-art technologies to rural and remote communities. And I'm going to speak Scott's language a bit on the rural and remote piece. But the people who have the worst health outcomes in our country live often in the most remote parts of the country, where access to care is awful and where access to virtual care is just as bad because of lack of internet, sometimes lack of other communication forms. So we have to, as in everything that we do in health care, think about who's being left behind. And there are some portions of our population who in the virtual care overhaul are still being left behind. And we have to collectively as a society make sure that we keep that in mind and not just enjoy our happy little phone calls and from a place like I'm in here, where I actually have good internet access, but not everybody does.
Right.
I'll just throw in another part of that equation that just highlights the perversity of our system. So until fairly recently, we actually didn't have access to our own health records. Like, it's not as though they're not even ours. Let's just suppose you have a thyroid issue and you need a blood test and you want to know your TSH value. You couldn't get it. If you wanted it, you had to physically go see the doctor. The doctor would not give it to you over the phone because the doctor couldn't be compensated for that. So you go all the trouble to go to the office and they say, here's the number, and you're done, and that's it. And probably if you have medication for thyroid, you probably know as much about interpreting TSA as the doctor, so there's not any value added to that. But it also, it speaks to an attitude, like who are we serving? We're serving the people, but you're the last person in the world that can have these results. Everybody else in the medical field can have your results, but you can't have your results. And fortunately, we are making some progress with that. When I started, I took the conversation in a negative direction, so let me try to jolt it into a positive direction, because I think two possibilities for improvement, and they're going to go hand in hand. The first one is if you take what Ontario is undertaking right now with the creation of the Ontario health teams, a very ugly history so far of how they got there. They seemingly violently changed direction from time to time, but they seem to be settling in a reasonable place, that they're appropriately in a geographical area. And what I particularly like is they bring in a broad range of service providers, including the coaches who guide people and where they may go for care, including physiotherapy and the like, not just the usual cast of characters. And the other part of that will meld is actually right in Jane's world. It is unmistakable that young physicians, those who in the medical schools right now and have graduated recently, on balance, want to work differently than their predecessors did. They're not interested in that standalone type of business model. They want something that's more akin to an employee relationship. They want to work in teams rather than individually, and they want to work more for salary with maternity benefits and sick benefits and the like. And that actually feeds in, I think, quite well. I think some are alarmed by that, and I think it's actually a good thing. I think it feeds in quite well with the concept of the Ontario health team. But of course, being economists, we all have two hands, so here comes the second one. The words are already nice when they're spoken, but if you read what's written down black and white in the Ontario legislation, it's not going to work, because the legislation reads like the Ontario ministry is still going to control everything. So the Ontario health teams will only work if they take the budget in its entirety and pass it to the Ontario health team and said, you divide it up. Then you can get scope of practice. But if it's all divided up, we had the local health integrated networks before, and their letters to their stakeholders were basically the letter that was sent to them by the ministry, and they changed the letterhead on it. And the legislation makes it sound like that's going to be that again. They don't seem to be able to let go. Maybe that will change once they're up and running and get some track record. But at least, hey, 2 out of 3, there's 2 promising moves I think that might happen, with one big caveat.
Right. Thanks, Don. Does anyone respond to Don, or we have so many questions coming in. I also want to make sure we have time for those. Scott, did you want to?
Yeah, I just wanted to sort of comment, not so much from Don, but to Mark's point about technology and the use of it. It's interesting to speculate when you have sort of catastrophic events or extensifications like this, what's actually going to change in the long run. And of course, with the use of technology and online shopping, there's a large school of thought that this irrevocably will be transformational change, that things will be done by technology now that wouldn't have been done before. But it's interesting just to watch the return of students to Queen's, or where I am to Acadia. Even students who are going to do the work online are going to do it physically located in one spot. And I remember last winter asking my strategy class at Queen's, who are the students who are very techno savvy, why do you buy and what do you buy online versus in the flesh? And they said, well, we're prepared to buy things online that we don't need to try out, or we don't need to size, or fairly simple things that we don't need to examine. I think that Mark is right on the healthcare technology side and the use of it for some things, but I'm going to bet that post-COVID, people are going to return to working in physical spaces. Students will come back physically to universities because there are things in our social nature as humans that are going to require that. So there'll be a good boost for the use of technology in certain spheres. But transformational, I don't know.
Anyone else?
Yeah, I think it'll be about finding the right balance, quite frankly. Yeah, and
sure.
There are some things where laying on of hands will still be important.
Many things.
So I want to turn to some questions from the audience now. Somebody has asked, earlier on you were talking about an effective collaboration in a healthcare system. So the question is, how do you think the various branches of healthcare, such as medical, dental, physio, pharma, et cetera, can effectively collaborate when they each have their own unique guidelines to follow? Thinking of COVID.
Well, Don started the discussion by talking about Ontario health teams, because to me that is an important development in Ontario, where success will be predicated on the ability of these various providers to work together and to figure out a way to deal with the boundary conditions that exist, to try to get rid of them to the extent possible. So I think that there's a vehicle to do it. I think, quite frankly, because of COVID-19, the development's on pause for the most part. There's some work going on, but not much. But it'll come back, because I think Ontario has placed a big bet on the success of Ontario health teams.
And I'd be happy to give a little bit of a local update on that from the Queens and Kingston community that I actually think is connected to COVID, because I think, as I said at the very beginning, that hospitals and home and community care, primary care, and long-term care have worked better together than they have for decades. And some of those lessons are going to translate into the Ontario Health Team model. So it's not a secret that there's a live Ontario Health Team application from this community that's currently in the hands of the government. And I think that it's stronger than ever because of the fact that we're working well together now. And I think the Queens and Kingston community is so beautifully prepared for the possibility of demonstrating what an integrated, seamless health system can look like. Don talked earlier about remuneration models for physicians and how many of them, particularly in specialist sectors, are still funded under fee-for-service. Well, we haven't had that here in the Kingston region for a very long time, thanks to probably some of you gentlemen have worked on the CMO structures in the past, and you referred to CMO earlier, Meredith, in your introduction, so that 350 specialists in our community work on a model that is an alternative payment model, and it's been highly successful. I actually think that Ontario government might be predisposed to looking at whether or not this is actually an effective model elsewhere. But we've got so we've got doctors that are working together. We've got one academic institution. We've got two fantastic hospital systems that are really collaborative. I hear CEOs of those hospital systems talking about the strength of primary care and the fact that effective health systems have to be rooted in primary care. If we can't demonstrate through an Ontario health team here in Kingston, Southeast Ontario region, what seamless integrated health systems look like, then nobody can. So here's hoping our application will go forward well, and we can actually put in effect some of the things that we've been talking about today.
Excellent. Thank you, Jane. Another question from the audience. Governments will be fiscally constrained in the coming years due to spending in response to the pandemic. How do you think that's going to impact the overall system and delivery of healthcare in Canada? It's a big one.
It wasn't that long ago when Ontario spent more money servicing its debt than paying for all hospital services. And, I think we're living in an extraordinary time now with interest rates so low, and Don can, this is Don's wheelhouse, not mine, speaking about fiscal sustainability, but all public services will come under strain. I can't see any public service getting a pass. So it'll mean doing better with less. And it's an old saw, but that's the circumstance we're going to be faced in, particularly when international lenders start to pay attention to the balance sheets of countries.
Don?
Well, here's a prime example where I think of the problem we had pre-pandemic is going to come right back at us, and it's going to come back even more forcefully. So we were concerned about the ability to fund healthcare before. And some thought that that had largely been solved. So across Canada from 2011 to 2019, healthcare spending only increased by 3.4% a year. That's about the pace of total revenues and total nominal GDP. And that looks like it's okay. But then you scratch a little bit before it, and we got there by starving infrastructure spending in the healthcare sector from 2011 to 2014. And that's already bounced back in our face and created the capacity problems that Mark did. And Ontario unilaterally cut physicians' pay by 3%. That's already been restored by the arbitration award. So that didn't work. And so we're going to get these pressures, plus the aging of the population as 1 percentage point of growth. So that's going to come right back at us. And to sweep in Jane's comment on the possible role of federal, or Scott, why one of the reasons why I don't think this national strategy will work. The Speech from the Throne is an amazing document in which it tramples all over provincial jurisdiction in almost every respect other than the funding one. I mean, there's a line in there saying we, the federal government, will ensure every Canadian has access to a family physician. As Jane said, we don't want to get in a constitutional discussion, but I can save you the trouble. That is not in the Constitution. That's actually somebody else's responsibility. And yet at the moment, despite what could be $100 billion a year of promises in the Speech from the Throne, they've said nothing about the Canada Health Transfer. So it is increased capped at the nominal growth of GDP, which in my mind is 3.5% with a floor of 3%. I bet when that was dreamt up, nobody contemplated nominal GDP actually declining in a level, which is going to this year. So we're going to crawl along the 3% for several years. Whereas provincial bill spending is going to go back to more like a 5.5 or 6%, and we're going to be back to the same arguments before. The federal share is 22%. It's going to go down sharply from that. Forget about cooperating and this and that because you can't even solve the problem we've got. So we're going to be back to that funding squeeze on the provinces, and they will do some crazy things that will not turn out to be sustainable. And there is a smarter way. You know, a lot of assumptions went into it, but if you look back way back in 2010, the Organization of Economic Cooperation and Development looked at a spending and they constructed a hypothetical efficient healthcare system and then compared what each government pays relative to that. And Canada was 30% over the hypothetical level. And I emphasize that is hypothetical and maybe it's not attainable. There was no country in the world that had zero and had to take the best of different features. But there is a probability, there is a possibility to do it. You know, a recent study from the Canadian Institute of Health Institute, 30% of all diagnostic tests weren't warranted. Many of them actually put people in danger. You can save manners of that. We like in Ontario now, we got 29 nurse practitioner-led clinics that are operating a way lower cost with high satisfaction ratings from people. There are things that we can do from that. We're all grossly over-medicated. We could address those type of things as well, but whether that will be done or not, I'm not sure. I mean, these are problems that have been there for decades and we haven't cracked them.
Being the cheerful optimism to the harsh reality of Mr. Drummond. The sort of things that Jane was describing are interesting and nice projects, prototypes, and things of that sort, but real change is going to have to be structural change. And really, it's only the feds that have that gathering ability. They have, I suppose, at least theoretically, the transfer tool, should they choose to use it. Governments years ago did, but in recent years they haven't. Recent governments haven't. But there's no one else who can actually bring the provinces and territories together and hammer out. And whether it's a national strategy for which Don and I have debated for about 7 years, or something in between, some kind of collaborative arrangement, unless we actually at that level get at health, human resources issues, seniors issues, pharmaceuticals, drugs, prescription drugs, unless we actually get at all of those things and bring them together into some kind of unified, uniform package, we're just going to tinker around the edges of what we've got now. And if there's no more money, as Don points out quite rightly in the system, then getting together and doing things difficult, or doing things together and doing difficult things will just have to be done less expensively, but that doesn't mean we can't do them.
Okay. Another question from the audience, Jane, to start this one off. How do we train the next generation of health professionals given COVID, right? What do we need to be thinking about in terms of training, focus, et cetera?
Well, there are a lot of interesting conversations going on around how we train, who we train, what we train them for, and I think some of these things have already been raised in this conversation around looking to what the needs of our health system are, which has never really been the way that we've decided to train health professionals. I mean, we all respect people's professional autonomy and the choices that we make. We've got to train a lot more primary care providers, whether we're talking doctors, nurses, or others. And I think some of us have already touched on that in terms of how we are going to make an affordable health systems in the province and in the country. The data is very, very clear that health systems that are rooted in primary care will give you the best health outcomes at the lowest cost in the most equitable and accessible way. But we continue to spend the bulk of our dollars on highly skilled specialists. We spend the bulk of our dollars at the very end of life. Don and others probably have the data memorized as to what proportion of health dollars are spent in your last 24 hours of life or in your last year of life, but it's an enormous amount. And so I think in terms of how we train health professionals, we really have to get at that front end. We have to build that broader workforce. Mark referred to the role of nurse practitioners and having them work to scope, stop fighting over turf, because there's more than enough work for all of us to go around. So if a nurse practitioner can effectively do a procedure that family doctors are largely doing now, then encourage that to happen. And if there are procedures now that are being done by specialists that family doctors can do just as well, especially if they have backup of specialists around, then we need to expand that. So it's a lot about what we're training people to do. I will just really get at the equity piece, though. Again, one of the big themes that we're looking at and how we train health professionals these days is looking at the fact that a lot of people are missing from the health system. We're not necessarily training a diverse population of health professionals who represent what Canada looks like. And so we're doing a lot of work in that area, which gets at the fact that we haven't touched on the fact that vulnerable people have been vastly disproportionately affected by this pandemic. We've talked about older people being disproportionately affected, but nobody has yet mentioned the fact that racialized Canadians are by far those who have succumbed to COVID, but also had positive cases of COVID, and that gets back to who we're training in health professions, and we've got a lot of work to do on equity issues in our training as well.
Thanks, Jane. We're almost out of time. I want to end on a high note, if we could, and get you just to give us, where we've got 3 minutes to the end, but a positive impact that you've noticed coming out of all of this. I mean, give us a high. Nobody's feeling too happy these days with what's going on. Can we end on a positive note? Each one of you. Mark.
Well, we've talked about this already, but I think what COVID-19 underscored is the success that organizations and healthcare providers can achieve if they work together. And that's easy to say. It's really hard to do. And I think that healthcare providers, whether you're an executive or a frontline provider, have figured out ways in which to make the interests of the patient or the customer prime through this event. And so I'm optimistic that this will stick. And I'm also optimistic that changes in education, particularly around interprofessional education, so that people learn how to work in teams when they're at school, will have a lasting consequence as well.
Excellent, thank you. Donald.
Well, mine is the way I started off. The breathtaking speed and breadth of action that governments have taken over the last 6 months make me less doubtful that these problems in the health sector can be fixed. I think now that they can be fixed. Whether there's a will and whether will be done, I'm still not so sure about, but I now think that it is possible to do it.
Excellent. Thank you. Scott.
I sort of look back at, how I thought about COVID, as it was developing. And like Don in a business school, I tended to sort of see things through the eyes of the financial community, which largely looked at COVID in terms of, is it going to be 2 or 3 quarters? Is it going to be a V shape or a W shape or a K-shaped recovery? But in any event, the recovery is going to come at least 3 or 4 quarters down the road. So a very short time way of looking at things. Whereas epidemiologists, people like Jane would know that if you look at the history of pandemics, really since the beginning of recorded time, they take a long time to work their way through. I mean, even the pandemics in the past century, Spanish flu, avian flu, Hong Kong flu, have all been at least 2 years. I mean, the Black Plague was 5 years. And so kind of the big takeaway I've got from all of this is sort of getting a sort of a sense of the timing and the magnitude of this problem done. And as we sort of prepare for the next pandemic, which will surely come 10 years down the road, I think it's the lesson learned of getting a sense of how big and powerful these things are and getting people ready and steeled to dealing with the realities. And, you see this, as I started off by saying, if you look at the health officers and politicians in general trying to speak very directly about the actual facts are something that's been a great success, I think.
Okay, thanks, Scott. And Jane.
I'll just close with talking about the miracle of health research, and we have never seen health research work at the speed that it has in the last 6 months ever. It is absolutely extraordinary that not only was the genetic code of this virus determined at breakneck speed, but now we have hundreds of vaccines in clinical trials, and it's extraordinary, and it speaks to the human condition and its ability to evolve.
Wonderful, thank you. I just quickly need to put in a plug for some of the other programming we're doing, and then I'll formally thank you. But I wanted to let our audience know that we do have online learning opportunities here at Smith School of Business. If you want to be an even better coach or leader, we've got Queen's Executive Education Programs offerings that might be just right. The Flagship Leadership Program, we've got programs in coaching remotely and on maintaining motivation through the pandemic, which personally I feel like a lot of us need right now. So check out this URL, smithqueens.com/execed for more information. That's the end of today's webinar. We normally hold these sorts of webinars every other week. Next week is an exception. We're going right to another webinar next Thursday. That's October 15th at 1 p.m. We'll be hearing from Smith School of Business Professor Elspeth Murray on the subject of embracing change for business success, lessons from the pandemic on leading change within your organization. So be sure to tune in for that. I want to say thank you so very much to all of you for participating. Jane, Mark, Scott, Don, you're remarkable. We could easily have talked for another hour or two, I'm sure, and I hope that you got something out of it. I know our audience did. We've had lots of comments and lots of appreciative thanks. So thanks very much to everyone for tuning in and to our panel for participating. And I invite you all to enjoy the rest of the afternoon. Bye.
Bye.